Thank you, Dr. Kayembe.
Thank you very much, Dr. Muller. So we just have been trying to learn how to manage type 2 diabetes step by step based on the GEMSA guideline with SEMSA guideline. This guideline will be updated soon, but even if we took some information from other guidelines that are more current, we align ourselves mainly on this guideline in South Africa. Again, it's all about money. We will try to treat our patients within the limit of our resources. And but one of the big message that we want to put across is, please, whenever you think of moving your patient from one step to another one, try to avoid clinical inertia. It used to be called therapeutic inertia, but it is in fact clinical inertia. All the time, reassess your patient response to the treatment, modify your treatment. Not more than 3 to 6 months should lapse without you assessing the response to the treatment and adjusting your patient treatment. So we should really avoid to drag our feet, because as we spoke even before, people tend to stay many years, regardless of how many tablets we put them on, being it while we just start with one tablet, or when we move them to 2 tablets, or even when we move them to tablets. The average is that we waste more than 7 years without moving our patient to where they should be. And we all know that as time passes, the disease progresses and the HbA1c control of our patient will deteriorate with time progressively. And just because we know that diabetes is a progressive disease, and every single year 4% of the beta cell function will be lost, which means that the disease of every single patient with type 2 diabetes changes, or the needs will change over years. We can start them, as you can see there, at when we diagnose them, they might respond to monotherapy, but as time goes on, they will need more than one drug and ultimately end up requiring insulin. Again, there is one thing: people still label diabetes and non-insulin dependent diabetes and insulin dependent diabetes. Those terminology have been thrown to the bin. So we need to remember this is type 1 or type 2. Type 2 diabetes with that respond to monotherapy, that respond to dual therapy, combination therapy, that will ultimately require insulin. So please let us stop using the insulin dependent and non-insulin dependent way of qualifying our insulin. So again, as the disease progresses, many patients with type 2 diabetes will not only require insulin, but they will benefit from insulin. So whenever we put it across, we should not put it as a curse. We should put it as a blessing, because if there was not insulin, these patients, after being controlled on oral, or some of them not even be able to be controlled on oral, wouldn't make it. So, and recognizing that we should be introducing insulin from the time that we diagnose our patient with diabetes as part of diabetes self-management education and support. And it should not be a once-off. Every time they come to us, we should be able to bring up, even if they are on oral therapy, even if they are on oral therapy and control, we should be able to discuss insulin therapy every time they come to us in a regular manner and in an objective manner. So we've went already through this. We know that step 1 is metformin, and we also know that step 1 can be step 1 plus, which is a subset, and it is every single patient that might need a treatment on top of metformin. And we need to remember those special circumstances or indication where step 1 should be upgraded. This is a step 1 upgraded. So, and the upgrade will be there, or the plus will be there up until toxicity to glucose is resolved. So, and it can be resolved by adding sulfonylurea, or it can be resolved by adding insulin to metformin from the get-go or at any time of the disease course. So those are some of the indication, the time or circumstances where on top of metformin, insulin or sulfonylurea should be added as part of step 1 plus. When we read the guideline, there is only step 1, but at any time it's written that you might need to give more than metformin to your patient. So every time that you diagnose your patient and the HbA1c of your patient is equal or greater than 1.5% above the target, you should upgrade step 1. Every time that you have a patient, that is the equivalent of, if you don't want to calculate by 1.5%, every time you have a patient that you diagnose and the HbA1c is greater than 9% and that patient is symptomatic, that patient should not be on metformin alone, but should be offered also sulfonylurea. When do you bring insulin as part of 1 plus is whenever the patient is assessed to have severe hyperglycemia. You can get that when your patient has a HbA1c greater than 10, instead of topping up metformin with sulfonylurea, you rather top your patient metformin with insulin, and it is on paper written, we should offer them intensive use insulin. It means in our setting, protaphane, or those that can afford and that are confident enough should offer to their patient the basal bolus. So it is HbA1c greater than 10. It should be fasting blood glucose greater than 14, random blood glucose greater than 16.7, meaning 17. So this, and we stress the fact that insulin is and will always be effective where other agents are not working, and insulin is critical, particularly when you have a patient that is catabolic. So whenever a patient comes to you, you diagnose your patient has been losing weight, that patient ideally on top of metformin should be given insulin. But we know how first the providers themselves can be scared of putting the patient on insulin or even offering insulin. And we also know the fear that our patient have to be offered insulin and to agree to start insulin. But there are now recent studies that have shown that sulfonylurea can as well help us and our patient to effectively treat hyperglycemia toxicity at the beginning of the treatment as part of 1+. Last time I spoke with, we shared and discussed, or it was mentioned the issue about money or not money and what other people do, and try to refine the second step when they offer or they start the patient on treatment. Regardless of wherever you are, the first step will remain and will always be metformin. But the second step, depending on you having money or not having money, will depend on you assessing your patient as having atherosclerotic cardiovascular disease, having heart failure, and or having CKD. In that case, if you have money on or have access, the drug of choice as the second step will be the GLP-1 RA receptor agonist or the SGLT2 inhibitors. Again, still, if you have money, you can choose, tailor your patient second step based on the fact that you don't want to expose your patient to hypoglycemia. In that case, the drug of choice that you will go for will be the DP4 inhibitor or the GLP-1 RA or SGLT2 inhibitor or even the TZD. Again, if you have money, you can go further and even care about your patient losing weight or not gaining weight by choosing your second line GLP-1 RA as the preferred drug. But we in public sector, we know that we should always mind the cost. We don't have access to these drugs. That is what we will be discussing going forward. So step 2, as we say, will be sulfonylurea. Sulfonylurea will usually be with metformin, unless metformin is contraindicated or unless metformin is not tolerated. And the GLP step 2, that is sulfonylurea, can be plus minus. Why do I say plus minus? Is that whenever you want to top up, if you top glimepiride step with intensive insulin, in that case, you cannot keep glimepiride. So, and this can happen at any stage of the disease when you see your patient. Step 1 or step 2, how do we adjust our treatment? It's all about the fasting blood glucose. One day we will discuss the cost effectiveness and the indication of self-blood glucose monitoring with patients that are not on insulin. But in this, currently, let's just remember that patient on metformin or patient on sulfonylurea, which is in our case in public sector, glimepiride, should get the treatment adjusted every 1 to 2/4 weeks based on the patient fasting blood glucose. And whenever we test that blood glucose, what is the target that will allow us to up-titrate the treatment accordingly is that our patient on metformin and or glimepiride should see the treatment adjusted based on the fact that they've reached or they've attained and sustained a fasting blood glucose between 4 and 7. And this is 4 and 7, an average of the last 2 reading of a weekly monitoring. So, but we also know that we can adjust, we should adjust treatment if the patient didn't have a blood glucose monitoring machine for self blood glucose monitoring, or if the patient didn't avail himself or herself to go to the clinic and get some readings done. In that case, adjustment will be deferred or delayed, which is something that we should avoid, because all our patients should get to the target by 3 months. So if you don't adjust treatment on a weekly, fortnightly, or a monthly basis, you will only be able to adjust treatment after 6 months when you assess your patient blood glucose, and you assess your patient HbA1c, and we all know that the HbA1c is a product of your patient fasting blood glucose and your preprandial or postprandial glycemia. And what are the targets? Whenever we ask about target, the first answer should be A1C. HbA1c is individualized. It can be by default 7%, but it can be as low as 6.5% or as high as 8%. But currently, people don't even go by 8 or reach 8%. And whenever you relax your target of HbA1c, you still need to remember that no patient should be allowed to have symptomatic hyperglycemia. So you cannot relax HbA1c to a point where your patient starts drinking too much, peeing too much, or losing weight. And once you get those targets attained, your patient should be doing their best with your support to sustain it. That is what we call controlled diabetes. So there is no patient that is controlled after you read or you notice the random of the fasting blood glucose when they came back to see you on that particular day. That is not control. Control is based on A1C. Despite the fact that it does have shortfalls, that is the best tool currently that we have for us to assess that our patients are controlled or not. So patient can be on step one or step two, but still experience hyperglycemia. That will be the time that will define that your patient status require insulin. And that is the topic of today, because we've moved our patient from metformin with glimepiride. Now they've done everything by the book, but because we know that the disease will be progressing regardless of whatever we do one day, and ultimately, as we said again, many of our patients will require insulin. And when they require insulin, how do we notice it? Is that they would have done everything by the book, they would have adhered to the treatment, but unfortunately, there will be readings that will show that they have a persistent hyperglycemia. And if that happens, then step 3 needs to kick in. And in our setting, step 3 is made of protaphane, which is neutral protamine agonist insulin, which is the most convenient insulin regimen when you initiate your patient and you move your patient from oral to insulin. So you add basically what will be basal insulin to your oral treatment. And just to show you, if you want to treat with insulin, you should think like the pancreas. The pancreas always secrete insulin and will top up all pulse produce insulin on top of the basal based on your patient oral carbohydrates. So it is not giving 10 units of actrapid again, because that is not the way that pancreas function. That is not the way pancreas think. So you cannot sit in your office, at the clinic, or at the hospital, or in the ward, only giving to your patient actrapid 10 units or as much unit that you calculate on any sliding scale that you want, without taking care of the basal insulin, because that is not the way that pancreas function. So what does basal insulin do? Basal insulin will take care of hyperglycemia overnight and everything that happened between meal. That is what the duty of basal insulin is. And how do we assess the effectiveness of basal insulin? We assess the effectiveness of basal insulin by checking the patient fasting blood glucose, not postprandial glucose, not the late afternoon glucose. If your patient is on protaphane, especially that we are talking about cost and access, please only advise your patient primarily to go home and solely assess fasting blood glucose. We've seen plenty of patients that have been started on protaphane, that have been given forms, and they've been given tables where they should record both fasting blood glucose and afternoon or evening blood glucose. That is just a waste of resources. At the beginning, if your patient is only on protaphane, what matters is the patient fasting blood glucose. And there are all these issue about analog versus regular. I hope we are all familiar with that. Protaphane is a regular insulin. Patients that will come from private will usually come with analog, or patients that are in private but that are using the medical aid will usually be provided with analogs. So this is just to give you an idea of the difference between the regular insulin. It is basically animal insulin that has been manipulated to look like human, that has been engineered to look like human insulin. And the difference between the regular insulin and the analog is that the analog tend to behave almost like the endogenous insulin, so insulin that is produced by human being directly. And the analog tend, especially when you use a basal analog will have a longer action compared to protaphane, as we will see. And when it comes to analogs that are rapid acting, they will tend to have the peak as soon as possible. So meaning you don't need to wait for 30 minutes when you use a rapid acting when you use a rapid acting analog, a fast acting or a rapid acting analog. So those are some of the things that we need to know. At time, people tend to make a fuss, and we might asking ourselves, why is this, that the government is giving us or giving to our patient only regular insulin while the private sector is providing analog? Yes, there might be less hypoglycemia. Yes, there might be less weight gain, but ultimately it has been shown that the glycemic control is the same. So even if the government doesn't go for the analog, or even if your patient would out of pocket afford the only regular, you should not feel defeated, because glycemic wise, they will work as well as the analog. So the only issue, the only main difference between the two is that when you use the basal insulin as analog, you tend to have less hypoglycemic episodes at night. So, and the other thing to always care about is that if you go analog, you need to be ready that you will spend more money than when you use regular insulin. So what is insulin that we call protaphane? Where do we fit it among the insulin? Because we all know that they are rapid or short-acting insulin, and at the other extreme, we have the long insulin or length insulin. So protaphane is an intermediate insulin. It is synthetic, it is regular, it is a human regular. It came from animal, but it has been engineered to really resemble human insulin. So it is an intermediate insulin. And when we talk about intermediate insulin, it is not about the onset of action, but about the duration of action. This is just what I've spoken about. So if you clock your insulin over 24 hours, so protaphane will, duration of action will be 12 hours on average, but it can last up to 18 hours. This is the data, the most recent data. So whenever you prescribe protaphane, you need to know that protaphane lasts about 12 hours, but it can last up to 18 hours. The onset of action, it is between 1 to 4 hours. This is for us to remember that whenever they inject at night, the insulin, so it starts working by 1 to 4 hours. So whenever there will be hypoglycemia, it won't be earlier than 4 hours. The peak of protaphane, again, it is somewhere between 4 to 6 hours. So if your patient injected protaphane by the book around 10 p.m., so the peak will be around 2 a.m. to 4 a.m. That is the time that if there is any hypoglycemia, that your patient, it is between 2 and 4 p.m. that your patient should test the blood glucose if they suspect that they've been experiencing hypoglycemia. That is just a summary of the duration, the onset, and the peak action. When do you ask your patient to administer protaphane? Your patient will administer protaphane based on what time you are telling the patient, and your patient will be able to test the fasting blood glucose, because remember we say we assess the effectiveness of protaphane by testing your patient fasting blood glucose. So if your patient will test the fasting blood glucose between 7 and 8, in that case, your patient should inject protaphane around 10 p.m. So basically, you will test the effectiveness of protaphane 9 to 10 hours after the injection of protaphane. So whatever you do, whatever time that you give to your patient, or whatever time that the patient report to you to be comfortable injecting protaphane, you should be able to tell them in that case, if you give your protaphane earlier, it means you need to wake up earlier for you to test, because we need the 9 to 10 hours later after injection glycemia for us to see if it is overnight, to see if it is working or not. This is still some of the data around. So whenever we inject, it means there will be a gap. Protaphane doesn't cover 24 hours. That's why using atraphane, we give atraphane twice a day, 12 hourly. It is because we know that there might be a gap between 6 to 12 hours without insulin, because protaphane is expected to work between 12 to 18 hours. So there is this the discussion around the patient that get atraphane or the patient that get protaphane that will wake up in the morning with hyperglycemia, and we tend to discuss, is it a dawn phenomenon, or is it a Somogy effect, or is it just because they didn't get enough insulin at time? Because we read this Somogy effect at the time we want to sound scientific or smart and want to bring it up all the time. But if you read the current papers, they will tell you that the Somogy effect should almost be thrown to the bin, because what is known now is that when your patient wakes up with hypoglycemia, at night they didn't have hyperglycemia, they had hypoglycemia. And when they wake up at night, in the morning with hyperglycemia, what is proven currently is that at night they also have hyperglycemia. So really, whenever you interpret or you review your patient self-blood monitoring, you need to keep in mind that the Somogy effect is not as significant as it used to be. What is significant is that either when they come in the morning, they have hyperglycemia, it means that the dose of protaphane that we gave them is not enough. We should not hesitate to increase, or it is just the dawn effect, because every time people will wake up, based on the fact that the growth hormone will be raised, cortisol will be raised, and catecholamine will be raised, your patient can wake up with raised glucose level. So take home message, yes, in theory, when they come in the morning, they've been given insulin at night. It might be Somogy, it might be dawn. We need to remember that it is most of the time because they didn't get enough insulin, especially in South African setting where the biggest meal of the day is supper. We need to keep that in mind. And when you want to really ascertain if there was Somogi effect of not, the critical time to test to ask your patient to check the blood glucose will be at 3 a.m. So if at 3 a.m. there is not hypoglycemia or there is a hyperglycemia, you need, particularly if there is a hyperglycemia at 3, it means your patient didn't get enough insulin. You should adjust by increasing insulin, not by decreasing insulin just because of the fancy known, spoken about, talked about Somogi effect. So we are at step 3 now. We've given our patient the protaphane, but we need to remember that the protaphane comes along with both metformin and glimepiride, because there is always this discussion about, should I keep the oral, among the oral, which one should I keep? Should I stop one of the oral? If your patient is on basal insulin during step 3, they also need to have both metformin and glimepiride unless one of them or both of them are contraindicated because of kidney problem or intolerance. And the dose at which this drug will also depend on, it can be the maximum, the target that we know, the usual target, or it can be the ceiling based on the fact that the patient is taking the reticular, for example, or it can depend on the fact that your patient can only tolerate 500 milligram of metformin or only 1 gram of metformin. And at step 3, we need to remember how critical it is to know your patient's renal function, your patient EGFR, and adjust the treatment accordingly. So everything between 60 and 10, it is critical for us to remember, because whenever it drops below 60, when it comes to glimepiride, we need to remember the 1 milligram. Whenever the EGFR is below 50, we need to remember that insulin or protaphane should be reduced by 25%. Whenever it drops below 45, the EGFR drops below 45, the maximum of your patient metformin cannot exceed 1 gram. And whenever it is below 30, your patient EGFR is below 30, some people that are very fearful will not only stop metformin, but also stop sulfonylurea. But we also know that sulfonylurea, stopping sulfonylurea can be deferred until your patient EGFR drops below 15. But below 15, we need to remember that when the EGFR is below 10, therefore your patient insulin should be reduced by 50%. This is long before your patient develop hypoglycemia. We never said, it is never written that a patient with CKD will not need insulin, or insulin will be, diabetes will be cured or reversed. It does state, it is only stated that they will need less insulin than patient with normal EGFR. So now that we've started our patient on insulin, or we remember that we should start our patient on protaphane. How much do we give them? We know that we should be starting them with the rule of thumb will be 0.2 unit per kg of protaphane. But based on at that time, when if it was already the time to decide to escalate treatment based on A1C, we will check 8 as the cutoff. Below 8, you can start your patient protaphane between 0.1 and 0.2. But if by the time you decide to move your patient to protaphane, your patient HbA1c was greater than 8, in that case, you might even give more than 0.2. So you will give your patient between 0.2 to 0.3 a unit per kg of protaphane. If you wanna suck it as unit, remember 10 unit is not a ceiling, it's just the minimum that can be given to a patient when you start somebody on protaphane, because at the time we see, we get scared of giving the patient more than 10 units. So 10 units is just the minimum, but the maximum that we can start our patient on is 20 units. So let's remember 0.2 if we want to be very academic, and if we want to be deeply academic, we need to remember that we will decide between 0.1 and 0.3 unit per kg using 8% HbA1c as the value that will tell us we go below 2, or we go 0.2, or we go above 0.2 unit per kg. And once we've started our patient on insulin, we need to set a target. We need to decide how frequently, what will be the scheme of titration. Will we be adjusting our insulin on a weekly basis, or we will be adjusting our insulin on a daily basis? And when we adjust our dose of insulin on a weekly basis, will we be adjusting according to the scheme that is called simple weekly basis, or it will be on a aggressive weekly basis? I will only discuss the simple and the simple rapid because it is easy even for our patient to adhere to and understand. So, and the other thing that we need to decide on, once we've chosen which scheme of increment or decrement we use, we need to decide how much will be the increment or how much should be the decrement whenever we prescribe protaphane. So you decide the protaphane, you need to remember the target, which is the fasting blood glucose. You set that target. You need to decide which scheme you will use, and based on the choice of the scheme, you will determine by how much up or down you will dial your patient protaphane. So the target, we've spoken about this already. It is a fasting one. The titration, as we said, the simple one, it is a weekly based titration. So even if your patient comes after 2 weeks, even if your patient comes after 4 weeks, if you want to use the simple weekly titration, what you will do, you will only use the readings of the last week preceding the follow-up. And you will average the last two readings and decide if they are on target or they are not on target. If they are not on target or they are on target on a weekly basis, you can increase or decrease your patient protaphane by 2 units. That is how simple it is. So you simply ask your patient to monitor the fasting blood glucose, not the night blood glucose, not the lunch blood glucose, just the fasting. And on a weekly basis, you only focus on the last two, you average them, you compare them, you view them through the interval of 4 to 7. If they are way up, you increase your patient, you ask your patient to increase by 2. If they are down below, you ask your patient to reduce by 2. That is how simple it is. The simple rapid escalation or titration will be if your patient is so motivated, if you can support your patient can adjust the dose of protaphane on a daily basis. And still you go through, you use the 4 to 7 as a target, and you can titrate by 1 up when the blood glucose is higher. But when it comes to, if it is low, now there is a difference. When you rapidly titrate your patient, when it is off up, you can only go up on a daily basis by 1. But if it is lower than the target, you should decrease by 2, because we don't want our patients to get hypoglycemia. We started the discussion with hypoglycemia. We know how deleterious the hypoglycemia can be and how lethal it can be. So that is so this is another way of titrating. You might not want to remember 1, 2, and so forth. You can just do it by percentage. So on a weekly basis, just increase or decrease your patient protaphane by 10 to 15%, which is easy. It is off, up, you increase by 10 to 50%. It is off, down on a weekly basis, or even try twice weekly, you can decrease your patient protaphane by 10 to 15%. If you don't want to calculate using the once or twice weekly, you just go up or down by 2 to 4 units. What time is it? We still have 10 minutes. I'm almost done. So how much protaphane can we give? This is another question that usually come up. It used not to be defined, and the temptation was that we can keep on pushing protaphane forever, but there is now the concept of over-basalization. And that concept, it is the number to worry about or to not go over is you should not give your patient more than 0.5 unit of protaphane. So meaning if your patient is weighing 60 kg, you stop protaphane when they reach 30 units. If your patient is weighing 80 kg, you can push protaphane until they get to 40 units. When you get above 0.5 units, there is nothing that you get out of protaphane. As you can see, using the last 3 columns there or bars, you will see that above 0.5, there is nothing that your patient is gaining anymore way or any longer when it's come to glycemic control. So don't give your patient protaphane beyond 0.5 unit per kg. If you get there, or even at the time before you get there, you should switch your patient to step 4. Failure to do that, all that you get when you go beyond 0.5 is just putting more weight and increasing the risk for hypoglycemia. And when we say that at the time we will wait for 0.5, but at the time we might not even wait for 0.5 and smell that protaphane is no longer working, is when your patient in the morning always wake up with hyperglycemia. You need to understand that protaphane at that particular dose, if the meals are not the issue, is not working for your patient. When you get your patient with a recurrent hypoglycemia on protaphane, you know that that protaphane is no longer working. If you check your patient self-blood glucose monitoring and you cannot make up your mind, it is today up, tomorrow down, all the time, it's keep on changing, it means that protaphane is not enough. You should switch the gear and send your patient to move your patient to step 4. And another time that you need to be reminded that you should move your patient to step 4 is when your patient fasting blood glucose is on target, but your patient HbA1c is off. It means that what is now contributing to your patient target not to be achieved is your postprandial hyperglycemia. And the closer we get to the target, the more significant the contribution of postprandial hyperglycemia becomes. So it will be telling you now it is the time for you to ask your patient to check postprandial blood glucose on top of the fasting, because the fasting has been correct, has been on target, but they didn't achieve the target of HbA1c. It means postprandial glycemia is off target. That patient now need bolus insulin, and it is also telling you that the beta cell function have further drops. It is time for your patient to change the gear. You move your patient from step 3 to step 4. Thank you very much.
Thank you very much, Dr. K. I just want to see if there are any questions there. That was a wonderful, very in-depth discussion on protaphane. And I'm sure we're going to be following that up with the next step after that in the next couple of weeks. I just want to see if there's any questions. People can either put questions in the chat, or you're welcome to put up your hand, or you can just unmute yourself and speak.
They should not be scared of sending questions through the chat. Apparently, the people that are scared to embarrass themselves. I don't know why. That's what they've been saying.
Okay, well, there is, I think, a function. If you look carefully, you can put stuff on the chat anonymously, if that helps. Okay, great. There's a question here, Dr. Kayembe. Is step 4 actrophane? Ooh, can we have a spoiler for the next episode?
What are they saying about the actrophane?
They're asking if that's the next step.
Yes, that will be the next step.
So yeah, so in the next presentation, there will be going to a lot more, Dr. K will go into a lot more detail on how to use actrophane. Any other questions? Find the anonymous button, or you can even send it to us directly if you're feeling that. But actually, there's no stupid questions. These things are actually tremendously complicated. And there's always new details, and there's always things changing as well. So what was true a year or two ago might not be true anymore. Great, just some. Well, excellent. I think that it looks like there's no burning questions at the moment. I think you covered everything everybody needed to know on the topic of protaphane. Dr. Kayembe, thank you very much. And again, this recording will be made available in the playlist with the other recordings for those of you that's missed any of the other steps. Otherwise, have a lovely evening, and we will send out the date for the next meeting within the next couple of days. Thank you very much, and thank you very much, Dr. Kayembe.
Thank you very much. Bye-bye.
Hold on, wait, there's one question. Oh,
Okay.
yeah, there's a good question. The question is when is protaphane given twice daily? Do we ever give protaphane twice daily?
It is given twice daily as part of atropine.
So yes, so we never use protaphane on its own as a twice daily regimen. The next step will be protaphane in a combination with a short acting and the actrophane, and Dr. Kayembe will tell us about that in the next session. Thank you very much. Thank you very much, everybody, and have a lovely evening.
Okay, bye-bye.